Welcome. We have a special event today. We have two excellent periodontists here, Dr. Zucchelli, Dr. Burkhardt. Welcome. And we're going to spend some time talking about soft tissue management today. All right? So both of you are experts in soft tissue. I'm going to start with you, okay? In general, I know you're very much into periodontal plastic surgeries, okay? Can you explain to the audience a little bit about the difference, or what is the advantage of doing periodontal plastic surgery versus the traditional surgery?
I mean, to answer this question, we have to check a bit the historical overview, how this kind of surgery developed. So it came up somewhere in the 60s out of the more or less aggressive surgeries in the US. That means in those times you were treating the periodontitis, and one did not know if you just can remove the tissues, the gingiva or not. And out of this, a kind of surgery developed named mucogingival surgery. A mucogingival surgery was defined as techniques to improve the relation between the gingiva and the alveolar mucosa. So within the next decades, out of mucogingival surgery, periodontal plastic surgery evolved. And we can say that there were several, I would say, landmarks in the time from the 60s till now that dramatically influenced the development of this kind of surgery. One was for sure the introduction of the implants, because the implant has to do a lot with also aesthetic appearance. Then for sure the regenerative techniques, because we have seen in those times that we cannot duplicate the very good scientific results into clinical environments. And later on, I guess, it was mainly the high expectations to the aesthetic appearance that went on and evolved this kind of surgery up to now.
So for most of the time when you do minimally invasive surgery, meaning that if you don't need to raise a flap, you stay away. If you don't need to reflect a flap, you try to stay away. Is that the ultimate goal?
Yeah. I mean, it's, for me, the time microsurgery is a bit misleading, because in a traditional way, microsurgery in fact means to use magnification, specifically designed instrument and fine sutures to improve the outcome. But for me, microsurgery is something else, and that's why I don't like the term. In dentistry, I would prefer the term mechanosensitive surgery, as it has more to do with how you deal with the tissues. And I guess the microscope is a help, maybe to practice and to learn this technique. But I'm personally convinced that you can also, with a high magnification loop, you can also perform a very good periodontal microsurgery.
Okay, so Giovanni, do you use microscopes to do your surgeries?
No,
I never see you do that.
I just use for picturing.
You just use for picturing, and I know that when you do surgery, of course, your surgeries are beautiful, very refined, but I noticed that most of the time when you graft, you raise a flap, you do a lot of things. Can you comment a little bit about the way, the difference from your approach versus the approach like, what Dr. Burkhardt has shown?
Yeah, it's difficult for me to say because it's not my field, the microsurgery with the microscope. I use quite big magnification. I use from 5 to 6 depending on the surgical procedure. And I personally believe that to make a surgery, always there is some mobility of the patient, there is some change of the position. And I think that the learning curve to use the microscope is quite long. While if you can look directly, obviously the problem is that we have always back edge, but it's okay. But I think you have a better control or easier control, especially when you are treating the palatal aspect, the palatal surface of the central incisors, the lingual aspect of the lower incisors. It's surface that I personally have better access if I use the loop, but this is most probably because I'm not experienced enough with the use of the microscope.
Right.
But I really don't feel the need. I don't know how I really can improve so much. Maybe the healing, the post-operative course, something that we still have to evaluate a lot. But in terms of coverage, for example, I think that we now reach about 100% of root coverage. So, I mean, You
No,
cannot
no, no.
improve 100% of
You-
root
you
coverage.
bring up-
And also in treatment around implants, we are very, very close now to big numbers. And so, in order to see the difference, you really have to evaluate something else that is not the clinical outcome most of the time.
Now, you bring up a very good point that a lot of people actually bring up the similar thing. I often been asked, what, is there much difference being really doing refined high magnification surgery versus just like, lower magnification and just do the more traditional way? Because people often say the difference between, really refined surgery, flap management versus a little bit more, maybe I'm going to use the term crude flap management, the difference is maybe 8 months, all right? So can you comment a little bit about that,
I see two aspects in that. I would say that there are interventions that you for sure get better results with a microscope. For example, apicoectomies. And this is you simply have to visualize an additional root canal or an isthmus between.
Sure.
Now when it comes to better outcome in periosurgery, I would say that, or I see things like that when you now compare retinal surgery, and you have a retina with maybe a thickness which is paper thin, and you work on your hand trimmer, which is essential in such an intervention, then with high magnification you can train your hands to become more precise. And today I see more advantage of a microscope exactly in these practical things, because you will agree when you close a flap, do you close the flap visually based or tactile based? I mean, what are you doing?
What do you mean?
When you close a flap primarily, do you guide your movements primarily by the vision or by the tactility?
Oh, only by tactility.
By tactility. So you see, that's why in the microscope, when you go very high, then you see things and you come to the limit of your hands. So that's why I guess with a microscope, you can practice your tactile feedback at the end that you have on your fingers. And personally, I'm convinced that this is not yet established in dentistry, but that the ranges that we apply are in kind of few grams, not in 100 or 200 grams like they are investigated in the literature.
Okay, so, but again, the biggest question is, does it really make that big of a difference? Now, what level of magnification do you use typically when you do surgery? Because he told us he used around five times or so. What magnification do you use?
Honestly, also in the majority of interventions, it's the same magnification, just by the microscope.
Okay.
And I agree to you that I guess so far it's not proven that we have any advantage by choosing high magnification in this so-called microsurgery in periodontology. It's not proven, few studies, and the studies are biased as well.
Okay, so again, that goes to a point. If a clinician want to learn your technique using the microscope versus your technique, what type of time frame do you think? Obviously, it sounds like it takes a little bit more technicality to learn to using the microscope. What type of time frame do you think it takes for someone from a beginner to be able to proficient enough to do surgery well enough?
When you say my technique, I would say maybe we use the same techniques, and the question is not what we do, but how we do it. So when you say you want to become fluent working on a microscope, it depends a lot on the person, on the surgeon, and of course on the training program that you establish. When I look back for it made maybe 1 to 1.5 years until I could fluently work on the microscope. And for sure you improve, especially ergonomics, when time is passing by.
Okay, and then with yourself, similar technique, but just using loops, I mean, what type of time frame would you say?
I think that the most important thing is really to know how to do it and what are you doing. So,
Right.
which is the flap design, which is the single sequence you have to follow in order to make the surgery, and not to, change every single time, how to suture, change every single time, how to make the first suture, then the second one, then the third one, then change again. So I mean, the schedule of the intervention is the most important thing that takes time.
Okay.
This is something that you really need experience, but from a handling point of view, I think also that 1.5 years, 2 years is the time that you need to start to achieve good outcome.
Okay.
But what takes much more time is really to know how to do it and not to do randomly, I mean.
Okay. Well, let's talk about, let's say, root coverage procedure. All right. Would like you guys to give a guideline to the audience. What do you seem to be important? All right. And maybe let's start with where would you prefer to harvest a tissue graft from?
I answer first the second question. The tissue graft became let's say it's in the past something that is very often applied in mucosal surgery. And I mean, there is not a list that I can tell you, there I use it. I think we should better think about what is the benefit of a connective tissue graft. So I would say the connective tissue graft, for example, when you have a concavity, can support a flap. And I also observe that with the connective tissue graft, a very thin graft, you can reinforce a wound. Because when you fix the graft somewhere in the neighborhood, you have another interface, then your flap is coming on a graft that per se is stable, and this is not the same interface that when you have a flap that is directly coming to the root. So the main, I mean, you can use it for volume augmentations, for many other things. In my clinic today, the main reason for it is not volume, but reinforce sites, and many, also for peri-implant defects.
Where is your preferred location to harvest the tissue?
Also, this is something interesting. Look, I mean, there are recommendations, and when you have a closer look, I see people on the stage very convinced promoting a different site. So it's always the question, what is the basis on what you talk? So what we have today in this field is, this is the way I do it, but that's all. Because we know that the palatal mucosa differs a lot. You have subpopulations of fibroblasts in the gingival margin on the palate that behaves completely different in the wound healing sequences than you harvested somewhere from the fatty anterior or in the rear area. So it depends on where, and I guess you have subjective observations, but not enough really solid basic
But in general,
research.
where is your preferred place?
So in general, I would say it's in the premolar area or in the tuberosity.
Okay.
Yeah.
And typically the premolar, the way you harvest it is submucosal, subepithelial, or how do you?
No, I harvest the free gingival
Free
graft.
gingival graft.
And it also depends, of course, on the size. When you have a huge size, then you go for the canine until the wisdom tooth.
Of course, of course. And of course, for you, we know that you make the free gingival graft deepithelialized very popular.
Yeah, just for in terms of when I use it, my really main and maybe only true indication for the use of the connective tissue graft in root coverage is when I don't have keratinized tissue in the flap.
Yes.
So the connective tissue graft is not used to cover, but is used to substitute the lack of keratinized tissue in the flap. Because if I have keratinized tissue in my flap, I don't use any connective tissue graft. The reason why I take the graft always in the posterior, I never take it in the premolar. I sometimes prefer to go to the other side instead of to take in the premolar, because as you were saying during your lecturing, to desepithelize the graft in the premolar area is a great risk to leave remnants of epithelium, and since you have to go deeper, you don't have good quality of connective tissue, but there is immediately fatty and glandular tissue. So this is the area where the epithelium is thicker and the connective tissue is poor. So I always avoid. The rugae, it's something I will never touch. I go to the other side. And the other thing, it's much more important, is that what we can do in order to be minimally invasive is not to reduce flap movement, but to reduce graft harvesting technique. And so if you go more posterior, if you stay as much as possible close to the teeth, far from the palatal vault, if you stay very superficial, I think you can minimize the discomfort for the patient.
And since both of you harvest free gingival graft and then deepithelialize it, one question I often hear from clinicians is when they deepithelialize it, they never end up doing it like the way you folks show it. It's like you folks show it so clean, one piece. They always like take a little piece here, take a little bit there, and in the end, they don't know whether that they left islands of epithelial tissue there.
Yeah,
What would you recommend?
Again, there is a technique, a specific way to hold the needle, the blade holder, a specific, which is not possible to see in the movie because you need a larger area to see, because it's really a specific technique to hold the needle, the blade holder. And you have to use the light perpendicular. You have to use a drop of water above it in order to make your cut very, very uniform. Obviously, you have to use not very, very small blades. Otherwise, you have to cut too many times for reaching the same thickness. And you also need a lot of experience. But again, it's something that with time, you have to do it because it's part of the surgical procedure. If you want to make the coronally advanced flap, you have also to desepithelize the papilla, so you cannot do it in different way than to use a blade. So, I mean, it's something that takes time, and so that's why it's important also to practice, but obviously it's something that you can really learn in a quite short period of time, but you have to practice on this.
So in your opinion, when you deepithelize it, what thickness of the tissue would you think you should remove? Or is there certain rules that you go by?
You know that the epithelial thickness also differs, but for sure we have 0.3 millimeters on the thickness. We also know about the rete pex, and honestly I'm convinced even if we have visually removed the epithelium, we will have remnants in the graft. But on the other hand, we have epithelial remnants in the ligament and in many other sites. I don't think about that this is a true problem.
I think in the posterior, the uniform of the epithelium is much uniform. So it's much easier to take it out in one shot, while in the premolar area, because of the presence of the rugae, it's even more difficult to desepithelize it.
When you refer to the posterior region, can you explain or define to the audience where in the posterior area, which area?
The best area is the 7, the very, very 7. Sometimes palatal to the wisdom tooth. It's a wonderful area. The patient don't feel nothing. If I cannot, I move to the 6. If I cannot, I move to the 5. Yeah. But it's very, very rare unless I have to take enormous, very, very long gap that I go to the first premolar. I did once last week in the canine. I will never do it in my life ever.
How often do you, in the literature, they reported like cyst-like formation sometimes. How often have you experienced this in your practice with this technique?
Can you repeat again, please?
In the literature, sometimes during the deepithelialized FGG, they have been report of cyst-like formation because of islands, like microcysts, of like islands of epithelial cell being left behind. Have you seen that in your practice?
Yeah,
or?
I have seen that, but you know, I cannot give you a number. It doesn't really occur frequently. Okay. It's a rare, I would say, a rare complication.
How about you? Very rare.
It is really very, very rare. Okay. It happens more frequently when you make soft tissue segmentation in the dentulous area sometimes. But the old clinical cases I can have in my mind, it happens once. And then after this, I didn't do anything else than, let's say, to push and to make some chlorhexidine and never repeat it again anymore. So it can happen, let's say, but no more than once every 2 years.
Yeah. So I was referred a case recently by another surgeon. They did the technique, there's a microcyst. And what happens, the chief complaint of the patients, they always feel like something's oozing out. All right, so I go in there and I just put a probe in there and try to track is that fistula. It is like underneath the cyst there's kind of like an enclosed compartment, you know. And so when people experience something like that, how would you treat it? Maybe I'll start from Zucchelli, then you, yeah.
Yeah, my experience is they never reach the root. It's very, very superficial. It's only, since I always maintain the desepithelialized surface of the graft outside, I never place inside, I never have problem of cysts towards the root.
Right.
Sometimes what can happen is that the flap shrink because you have too much amount of epithelium, and so you have graft exposure. And this is something that, from aesthetic point of view, maybe can be not so nice for the patient because of the difference in color between the adjacent teeth. But most of the time you really have just to enlarge a bit, because the patient, the only thing that the patient can tell you is that he feels some swelling, you know?
Yes.
And when you push, it's not hard anymore, but it's much more smooth. And so when you push this, there is this very, very white, dense liquid that gets out. And after that, most of the time, nothing happens. Sometimes, after a few months, you see some island of not cyst anymore, but epithelium exposure of the underlying graft.
Sure. Yourself?
Yeah, I mean, I observed this as well. And at the end, you also could do such an ovoid excision of this area. That's really...
Sure. Okay, so with the last couple of minutes, can you just, we will just talk about a few factors that is important for you for root coverage. Flap thickness, okay? Where do you draw the line and say, all right, I need to put a substrate in there, or you just, coronally just reposition it? How do you make that diagnosis? Let's start from you.
You cannot say, we know this data from literature, 0.8 millimeter or whatever. I think you should also take into the consideration where you position your flap. When you have a huge avascular area, it's not the same as when you have, let's say, a small area with a ligament in bleeding from the side. So I think it's individual, and I cannot give you a number related to that.
Okay.
Yeah, I agree, because it doesn't make so much sense to measure the thickness of the flap at 1 millimeter, 1.5 millimeter distance from the soft tissue margin, since this is placed on the crown most of the time. When you advance the flap, you not place the flap at the level of the cement enamel junction. So even if you have 1.5 millimeters of keratinized tissue, the whole flaps, the whole alveolar mucosa is on the root, and this is very, very thin. So, it depends really how much you advance the flap, how much keratinized tissue you have in your flap. So it's something that still has to be evaluated.
One more question. How about flap tension? How do you view it? Yes.
Yeah, this will be one of my topics today.
Sure.
And honestly, I think flap tension is something that is just mentioned, let's say, from tradition. You say passive wound closure, even if you never investigated in detail if passive flap tension really yields the best results. I think when we go for a root, there must be visual or tactile tension on the root. Maybe it's different when you are on a connective tissue wound bed, and still, I would say the tenet of passive wound closure for sure is still valid, but it's time maybe to revise this tenet.
Okay. One last comment.
We don't know so much. What we know is that for sure what creates tension at the time of the surgery is many, many things. The patient vestibulum depth, the presence of vertical release incision, not so many, many things. While what is more important, since we don't have data about so much, it's better to remove as much as possible the muscles from the alveolar mucosa of the flap. That's the best way to say, most probably, I don't have tension enough.
Well, it's been a fun time spending time with both of you, and I'm sure the audience love it. Thank you again.
Thank you very much. Thank you.
Thank you. It was a pleasure.
Thank you.
Okay.
Okay.
Thank you so much.
Yeah.